Yeah, good afternoon already. To everyone, dear colleagues, thank you very much for joining us for our this year's presentation theater on an extremely interesting and exciting topic, moving from ADAMTS13 to lupus, anticoagulants last year's, to hemophilia this year. And I'm very excited sharing the podium here with three really experts in the field from treating and patient management of hemophilia patients, diagnosing them, and with Bert Verbruggen, the expert in factor, yeah, very loud, in factor VIII inhibitor testing. Without further delay, let me introduce you to our first speaker, Professor Ingrid Pabinger from the Medical University of Vienna. I don't think I have to introduce her further. Multiple clinical trials, hundreds of publications, president of the German Society, the ISDH, and a real expert and extremely brilliant physician. Thank you very much for joining us.
Ladies and gentlemen, thank you for the kind introduction. So it's today my task to discuss with you why inhibitor testing is crucial for the management of hemophilia A. Okay, these are my disclosures. Well, first and foremost, it is the most important fact to say that treatment options for patients with hemophilia A without and with inhibitor are different. In patients without an inhibitor, we can use standard factor VIII concentrate and extended half-life concentrate, bispecific antibodies, rebalancing treatment, and more recently, of course, gene therapy. When a patient has a factor VIII inhibitor, treatment options change. Factor VIII can, in patients with high titer inhibitor, no longer be used. We need alternative treatments for bleeding, and these might be fiber or activated recombinant factor VII. But also in those patients, we can use bispecific antibodies and rebalancing therapies, and at present, no gene therapy. There are studies going on or are planned. It's also very important to mention that the presence of an inhibitor leads to a higher mortality in patients with hemophilia A. And this is a study from the US, a retrospective surveillance on data of more than 7,000 patients with severe hemophilia. And the odds ratio for death in patients with an inhibitor was 1.7. So a patient with an inhibitor has a 70% higher risk of dying. And there is also a difference with regard to causes of death. So patients with inhibitor have more often bleedings compared to those without an inhibitor. And specifically, I have to take it, otherwise it doesn't work. Of course, the risk of cerebral bleeding is high in patients with inhibitor. Let us look at the incidence of a factor VIII inhibitor in patients with hemophilia. And these are the data from the Rodin study published in 2013 in Blood. And these children were observed from the very beginning, primary untreated patients, PUPs, at the initial phase of factor VIII treatment. And as you can see here, all inhibitor patients, we have an incidence of approximately 30%. And what's also very important to look at is the incidence of high titer inhibitor. So those patients can no longer be treated with regular factor VIII. And the incidence after 50 treatment days, there is a plateau. This is the curve in the middle. The high titer inhibitor is at about 20%, and that's high. So every fifth patient with severe hemophilia gets an inhibitor, and it is no longer possible to treat this patient with a factor VIII concentrate. How did this incidence evolve over time? Is there any difference or not? Let us go back to early times of inhibitor determination. In Vienna, this was started in patients with Hemophilia A already in the 1960s. And this is a cohort of patients that was observed. And you can see in this very first study that looked at incidence and not prevalence, at incidence of inhibitor development, this was 24%, very similar to more recent data, and the cumulative incidence for high titer was 20%, so very similar. And on the other end, we have inhibitor incidence in 2023, published recently by Kathleen Fischer, 509 patients treated between 10 and 2020. And again, we have the similar incidence, cumulative incidence of high titer inhibitor below 22%. So with regard to that, nothing has changed over many years. Well, there are recommendations for the initial and follow-up screening for inhibitors in severe hemophilia A. And as we could see from the incidence curves, the risk is highest in the very first days after treatment, even within 10 to 20 days. Therefore, it is suggested to determine an inhibitor every 5 exposure days until 20 exposure days. After that period, an inhibitor determination is suggested to be performed every 10 exposure days until in total 50 exposure days are reached, and then 2 times per year until 150 exposure days, where we then really have a plateau. And then afterwards, at follow-up screening, annually thereafter, or when, of course, it's clinically indicated, and I will look at various situations, before and after surgery, before and after switch to a new product, and if positive, of course, to repeat and check the recovery of the factor concentrate. An inhibitor can occur even in regularly treated patients after 150 exposure days. And this is a prospective study where the incidence of de novo inhibitor formation in previously treated patients, PTPs, were investigated, and indeed it's low in patients who are regularly treated with factor VIII concentrates. It was 1 in 340 patients. And this is an example of one of our own patients who was age 20 and had more than 75 days of factor VIII exposure. He was on regular prophylaxis, and at a sudden he developed abdominal pain and had hypersensitivity on the right thigh. And we know that this is very typical for bleeding in the psoas muscle that you can see here on the right side. The psoas muscle is enlarged, and this is the bleeding in this patient. The patient had previously, and this was determined many times, no inhibitor, but when he manifested with this severe, and if it is not treated adequately, even life-threatening bleeding, an inhibitor was detected of 8 Bethesda units. And when we measured the factor 8 in that patient, it was unmeasurable, less than 1%, despite he had taken 40 units per kilogram body weight just 6 hours before he arrived at the hospital. This patient was then effectively treated with immune tolerance induction. Well, we have those most recent WFH guidelines for the management of hemophilia, and I will, in my presentation, also present some of those guidelines with regard to inhibitor determination that are published in that guidelines. So, but we talked about inhibitor induction, and it's very clearly stated in this guideline that the inhibitor testing also guides the duration of the immune tolerance induction. The immune tolerance induction is a regular treatment with factor 8 and higher doses than usual. We have different regimens, and I won't go into detail. Some of the regimens even give twice a day a high dosage of factor 8, and this is really very cumbersome for the patients, the parents, and also, of course, for the caregivers and the insurances. And there is a definition in that guideline that a successful immune tolerance induction is defined as a persistently negative Bethesda titer. And this has to be accompanied also by normal pharmacokinetics, but to bring down the inhibitor and to make it unmeasurable, that's the first aim by immune tolerance induction. Inhibitors can also occur in patients with mild hemophilia, patients that have between mild and moderate hemophilia, so between 2 and 40%. And these are 2 examples that we published in 2012. Patient 1 has a baseline inhibitor of 8%. And these are 2 adult patients, already has been treated various times before. And he had an intensive treatment due to muscle bleeding. And as you can see on the right hand, I don't think that I have a pointer, but look at the red line, yeah? After this treatment, there was an increase of the inhibitor up to more than 50 Bethesda units, so a real high responder. And what is also very interesting is that the endogenous factor 8 comes down to less than 1%. So the inhibitor triggers that the patient goes from a mild to a severe form of hemophilia, and very similar the second case. We know that patients with mild hemophilia, the risk is substantial to develop an inhibitor. After 50 exposure days, 6.7, and there is no real plateau. After 100 exposure days, 13%. Well, we need also inhibitor determination in patients on bispecific antibodies. Emicizumab is now available, because if patients that are not treated or treated with a low amount and then are on emicizumab, they might develop an inhibitor after additional factor 8 treatment. In patients with an inhibitor, of course, we want to know the inhibitor status to decide on the type of treatment when there is a bleeding, whether we can use factor 8 or whether we have to use alternative treatment options. What are the indications for inhibitor testing after initial factor exposure. This is also from the guideline after intensive factor exposure for recurrent bleed, so when there is a worsening of the clinical picture, for lower than expected factor recovery, suboptimal clinical or laboratory response before surgery to make sure that the patient will respond to factor VIII, and when there is suboptimal response. And I'm coming to the end. Why is inhibitor testing crucial? Because the treatment is different. The strength of the inhibitor is crucial for treatment decisions. Patients with severe hemophilia are at high risk at the beginning when they are young and receive the first factor VIII, may also develop later an inhibitor, also in patients with moderate to mild hemophilia. And this is a greeting from Vienna. Thank you for your attention.
Thank you, Professor Pabinger. We are going to have a Q&A session at the end, so all the three presenters will have time at the end for some questions. And may I now ask Professor Gary Moore to the podium or to the stand and presenting about how we are doing it now, the testing, and what are the problems we face. Gary, please.
Okay, thank you, Nicholas. Okay, so we've seen why we need inhibitor testing, so let's have a look at how we do it and some of the problems we encounter while we're doing it. Now, today, of course, we're concentrating on measurement of factor VIII inhibitors, but a lot of what we say will also apply to measurement of factor IX inhibitors. And I've also put this slide up because I thought you might like to meet Stephen Christmas, who factor IX deficiency is named after. And it's a pure coincidence that the paper was actually published in December of 1952. So, as we've seen, inhibitors are a major complication of replacement therapy because the immune system doesn't recognize the infused factor as self. Absence of factor VIII or those with severe molecular defects have a much greater risk of developing an inhibitor, and in fact less than 10% of patients with non-severe haemophilia will develop inhibitors, and some of them are non-neutralizing. They don't actually interfere with function, but they're of questionable clinical importance. But the factor VIII inhibitors that do inhibit, they do actually operate by a number of different mechanisms. Some of them actually inhibit the binding to factor VIII, so that to von Willebrand factor rather, so the factor VIII is left on its own and it gets destroyed by circulating enzymes. Or the inhibitor will inhibit the activation of factor VIII by thrombin or 10A. Or they may inhibit the interaction of activated factor VIII with the 10A's complex, and some of them will actually directly destroy the factor VIII themselves. We mustn't forget we're also talking about acquired haemophilia, which is almost always acquired Hemophilia A, and we're talking about those antibodies as well. The elephant's there because they never forget, and he's there to remind me to mention that the reduced factor VIII that we see in von Willebrand's disease is ostensibly also acquired haemophilia, but of course it's not immune mediated. The very first description of an antibody, an inhibitor after factor VIII infusion, was described in 1941 with very basic mixing studies. At the time, they didn't realize it was a factor VIII inhibitor. And it wasn't until 1959 that the first quantitative mixing test-based assay was described. It was the Oxford method. It had a 1-hour incubation time and looking for a 75% reduction in residual activity. And later on in 1973, they modified the assay, and you could vary the starting point of factor VIII, and the incubation time, horrifically, could be as long as 4 hours. But rather fortunately, a couple of years later, the great and the good got together in Bethesda, Maryland, USA, to standardize factor VIII inhibitor testing, and then the Bethesda assay was born. Now, here's the Bethesda assay that we're all familiar with. We consider factor VIII inhibitors to be time dependent. That's actually not strictly true. The inhibitors will work straight away, but they actually have to hang around and wait for the von Willebrand factor to very slowly release its cargo before the inhibitors can actually have their inhibitory effect. So that's why we have to incubate for 2 hours. So in the standard Bethesda assay, we add exogenous factor VIII to the plasma that may or may not contain an inhibitor, incubate at 37 degrees for 2 hours to allow for this progressive neutralization. 1 Bethesda unit of inhibitor is equal to the amount of inhibitor that will neutralize half of 100% of factor VIII in normal plasma after 2 hours incubation at 37 degrees. And as you know, factor IX inhibitors are not time dependent, but otherwise the assay is virtually identical. If you have a very potent antibody, just doing that initial single dilution won't be enough to find or to be able to quantitate it, because it will destroy all of the factor VIII. So you need to make a series of dilutions. I've got doubling dilutions here, they don't have to be. Make those dilutions in buffer, and then add to each of those dilutions an equal volume of a normal plasma that contains exactly 100% factor VIII. You also prepare what is called a comparative mixture, which also has the same starting amount of factor VIII and then the same amount of buffer as the plasmas. So you've got an overall same volume reaction mixture. Cook them all for 37 degrees for 2 hours, put them on ice to stop any further antibody-antigen reactions, and then assay for residual factor VIII in all of the dilutions. And you can see for this particular patient, the antibody was so potent there was no factor VIII left over in the neat and the 1 in 2 dilutions. But then as we progressively dilute out the inhibitor and its potency, more and more factor VIII is left over until eventually at the very high dilutions we become homeopathic, and there's as much factor VIII left as there was when we started. So we've got to turn these raw data into a Bethesda titre, and we can do that by drawing a Bethesda graph. We want to plot the residual factor VIIIs that are spanning the 50% mark. I'll show you why in a couple of slides later, and then we can read the 50% value off of this graph. And you could see, had we done a 1 in 17 dilution, like who does, we would have found a 50% level, and this patient has 17 Bethesda units of inhibitor. Alternatively, we can use the ideal Bethesda graph. Clearly, 0 inhibitor leaves you 100% residual, 1 unit leaves you 50%, 2 units leaves you 25. Read your result off of this graph, multiply it by the dilution factor, and you have your Bethesda titre. So have a look at patient 1, analysed undiluted, got a result of 0.7, multiply it by the dilution factor, which is 1, and you have a titre of 1. Patient B, 3 different dilutions, multiply the residuals by the dilution factors, and they're all roughly giving the same result. Strictly speaking, you should report the result closest to 50%, but you wouldn't be wrong to take a mean value of 8.3. Now, patient C is quite interesting because the more we dilute them out, the higher the titre goes. We'll have a look at them on the next slide, but as I said earlier, make sure that you read the results somewhere between 25 and 75%. That has never been validated. It is probably different for every patient, but that's a rough guide. And as I say, take that reading that's closest to 50%. But our patient C had a different type of antibody. We have 2 flavours of antibodies. The type 1s, they're the simple first-order kinetic antibodies. They are alloantibodies that directly inactivate the factor VIII in direct proportion to their concentration. And if there is enough antibody, you will get complete neutralization. And if you look at the graph on the right with the straight line, if you incubate it long enough, there will be no factor VIII left over. But our patient C had a type 2 complex or second-order kinetic antibody where they have an initial rapid inactivation phase, and then the antibody and the antigen reach an equilibrium, they dissociate, and there'll always be some measurable factor VIII. So if you look at that graph, you can incubate it forever, and there'll still be some factor VIII left over. And that makes finding these antibodies and certainly quantifying them accurately in a Bethesda assay quite difficult. And we tend to see these in the patients who have got acquired haemophilia. When it comes to drawing our Bethesda graph, you can see in the type 1 patients that you do at some point get a linear portion of the graph. That's the reason why we're looking for somewhere between 25 and 75, and we can read off the 50%. But look at the type 2 inhibitor when you're trying to plot the Bethesda titre. It is not linear, and you'll never get a linear graph. So the advice there is always to take the result that is closest to 50%, which may not be the right one, but that's what we do. I have to point out that Technoclone does have a Bethesda reagent kit, and very usefully, the normal plasma does have exactly 100% factor VIII in it. We used the Bethesda assay for a good 20 years until this very clever guy who's sitting just over there, Dr. Bert Verbruggen, came along and brought to us probably the single most important modification of the assay and changed the way we all practice ever since. Because Bert and his team noticed that there's a few problems with the classical Bethesda assay. The factor VIII stability isn't too good because the pH drifts upwards after 2 hours, plus the fact you have reduced and variable protein concentrations because you've got all those dilutions. And these lead to non-specific inactivation of factor VIII. So what Bert teams did is modify the assay by directly buffering the normal plasma to maintain the pH, but instead of diluting the patient's plasma in buffer, it was diluted in factor VIII deficient plasma to maintain an identical protein concentration throughout the assay. And a subsequent publication of Bert and his team, they showed that in place of factor VIII, you can use 4% bovine serum albumin because we have to be honest, it's a little bit cheaper. I mentioned these for completeness. I'm not going to go into them in detail, but there have been some other modifications since then, the Malmo method and the Osaka method, but time prevents me from going into them into more detail. But so that's how we do the assays, but like any assay we do in the hemostasis lab, they're not perfect, and we have to be aware of the limitations. And one of the big limitations is that for various reasons, patients can have circulating factor VIII, and the moment they have circulating factor VIII, it completely violates the assay principle. Everybody has got to have the same starting point of factor VIII, otherwise you can't compare one assay to another, one patient to another. So the solution to that is to heat treat the plasma, the patient's plasma, at 56 degrees for at least 30 minutes. And what that will do is release the factor VIII from the antibody, and that temperature will denature the factor VIII, but not the antibodies because they're a little bit more robust. However, if you leave that incubating too long, much longer than 90 minutes, then you will start losing antibodies as well. Once you've done that, centrifuge before you do the assay, and it actually helps in identifying the low titer antibodies, but it does add a lengthy pre-analytical step to what is already a lengthy antibody, assay rather. Now, interesting enough, if you look at EQA returns, even now, not everybody uses an Nijmegen, and a lot of people who think they use a Nijmegen, they don't. They might buffer the plasma, but still dilute in buffer, or they might dilute in BSA, but not buffer their plasma, and equally some will heat treat and some won't. And this is probably one of the reasons why we still see quite a lot of variation in EQA returns. When you're doing a Nijmegen, one of the important sources of error, you might think it's innocuous, but the quality of the factor VIII deficient plasma that you're using. Chemically depleted plasmas are a no-no because although the factor VIII has been denatured, some of those fragments can retain intact antigenic sites, and those fragments will steal the antibody before you actually get a chance to measure it. But also the process of chemically depleting can also activate the factor V. So they're really a no-no in a Nijmegen assay. But that's fine, because most of us use immunodepleted plasmas anyway. But they're not perfect either. Another one of Bert's publications with immunodepleted factor VIII deficient plasma showed that if the von Willebrand factor is reduced in your factor VIII deficient plasma, you will get different results. But also in the immunodepleted plasma, some of the antibody that is in the Cepheros column that you use to make the plasma deficient in the first place, it might co-elute, and then you end up with an antibody you don't want to measure, you don't want it to contribute to your assay, and that will affect the results. Subsequent studies have suggested that maybe the von Willebrand factor isn't so much of a problem, and probably it is these co-eluting antibodies that are causing those problems. But that's not a problem, because there is a solution. Use suitably prepared congenitally deficient plasmas, and I'm obliged to mention that they are available from Technoclone for both factor VIII and factor IX. And you can see that Captain Severon has taken to juggling the reagent bottles, even though we have asked him to stop doing it. But to be fair, since we took that photo, he's actually up to 5 bottles now. So he's actually getting very good, but it makes it difficult to do stock checks. But also, as I mentioned earlier, you can just use 4% bovine serum albumin, which does actually give you improved VIII stability. And of course, remember, there's no von Willebrand factor in bovine serum albumin anyway. Your factor VIII source, we tend to think that normal pool plasmas are all the same, and I'm afraid they're not. So you have to be very careful with your factor VIII source. You can't assume that it's definitely got 100% factor VIII. So the ICSH guideline that was only published a couple of weeks ago, they suggest if you're going to prepare your own normal plasma, and you need a minimum of 20 donors. Now, I would actually argue that when you consider that factor VIII in the normal population has a trimodal distribution, I've seen other papers suggesting a 50 donor minimum, and I certainly would go for that. And there's a very useful table in that new guideline that shows the difference. The further away your normal plasma is, whether it's too high or too low from 100%, it can make a significant difference to your Bethesda titre, because if the factor VIII is too high, the antibody has got to work even harder to come down to 50%, and you're going to get a falsely reduced titre, and of course vice versa if the factor VIII is too low. And the guideline allows a maximum deviation of plus or minus 5 international units. So an alternative will be to calibrate your normal pool plasma to make sure you know what's in it, or buy a plasma that you know has got 100% factor VIII, and again, they are available from Technoclone. If you're measuring your residual factor VIII with a one-stage assay, and of course a lot of us do, then all the usual suspects are potential interferences. So more recently, perhaps not surprisingly, we're seeing papers being published showing that you can use a chromogenic assay instead, and most of them say that you get not only equivalent results, but actually probably the results are more specific if you've got low titers. And of course, we have to remember that if the patient is on emicizumab or mimate, you must use chromogenic assays that have got bovine source reagents. So, in an ideal world, a factor VIII inhibitor assay would be far less technically demanding, have a much shorter incubation time, fully automated, and just overall much less time consuming. Well, I'm going to leave that to our next speaker, Dr. Bert Verbruggen, to tell you about that, because he's the king of Bethesda assays, and he's going to tell you how we can solve some of those problems. Thank you for your attention.
Okay. Good afternoon, everybody. Gary, thank you very much for your nice overview of the state of art of inhibitor testing, the current state of art of inhibitor testing. And Dr. Binder, thanks for the opportunity to show my results of a new factor VIII inhibitor assay here today. So I have to spend a lot of words about this, because Gary also have shown you all the ins and outs of the inhibitor assay, the general inhibitor assay, and especially the Nijmegen inhibitor assay. And it has not changed a lot since the introduction in 1995, except for the preheating of the patient plasma. That was not included in the original publication. And later on also the change of the factor VIII deficient plasma, the possible change of factor VIII inhibitors plasma to 4% BSA. And finally, of course, the introduction of the chromogenic assay instead of the one-stage factor VIII in activity assay has occurred during the last 25 years. I received this slide from Piet Meijer, from director of the ECAT, and it shows the relation between the coefficient of variation at the y-axis and the inhibitor activity on in Bethesda unit on the x-axis of samples that were distributed in the period between 2015 and 2022. And what it is about, it includes 30 samples, of which five of the 30 samples have an inhibitor lower than 1 Bethesda unit. And it is clear that at the lower end of the inhibitor activity, lower than 1 Bethesda unit, the coefficient of variation with the Bethesda assay is much higher compared to the coefficient of the interlaboratory CV of the Nijmegen assay. And that's of course because the Nijmegen assay is much more specific at the lower inhibitor activities because of buffering of the normal pool plasma. But as you already have seen on this former slide, the inhibitor, the CV of the higher inhibitor activities, so above 1 Bethesda unit, is still, after all these years, is still very high, between 30 and 40%. And now what's the problem? What's the problem with the general inhibitor assay and also with the Nijmegen assay? Why remains this coefficient of variation so high? I think, among other reasons, the first reason is, of course, the long incubation times in all the factor VIII inhibitors until now. As you see here, you see here what happens during these incubation times. It takes at least 2 hours to fully inhibit the factor VIII that is present in the matrix of this assay at 37 degrees and much more time at room temperature. And that makes the assay very complicated. And this complication is the liquid handling. It takes a lot of time and a lot of work to finally get the results of an inhibitor assay in this way. And the long incubation time does not allow automatization. So it is all work, with manual work. And despite immense innovations in both hardware and software technology and biochemical innovations in the past 30 years, the factor VIII inhibitor assay is still a mainly manual processed and time-consuming procedure, resulting in very high interlaboratory coefficient of variations. And so we hypothesized that in the absence of von Willebrand factor in an assay medium will dramatically accelerate the inhibitor finding to factor VIII, allowing automatization of the test. And you can see it here. We in the red line represents an experiment where we mixed in a matrix that was completely free of von Willebrand factor. We mixed recombinant factor VIII without von Willebrand factor and a sample with an inhibitor. And it is clear that after a short time of incubation, the shortest time, I don't know anymore, this experiment I performed already a number of years ago, but the shortest time I think is 10 or 15 minutes. And after mixing of the recombinant factor VIII and the inhibitor, in fact you get a more or less immediate inhibition of the factor VIII. And so we started to develop a new, fully automated, rapid inhibitor assay by use of a full-length recombinant factor VIII Koval-3 wire as a substrate, incubating 20 minutes of preheated sample and Koval-3 of 1 unit per ml. After incubation, measuring of the residual factor VIII activity with homogenic substrate method containing bovine serum albumin, and execution of all steps in a coagulation analyzer with an onboard ability of 3 subsequent sample dilution steps and 3 reagent addition steps. It is the Saffron from Technoclone. And in detail, this is how the assay runs. So first of all, you have to heat inactivate your sample at 30 minutes during 30 minutes at 58 degrees. And you can choose eventually manually dilution of your sample, or you can also perform the dilution within the Saffron. Once you have inserted the sample in the machine and press the start button, mixing of equal volumes of buffered Koval-3, 1 unit per ml, pH 7.4, with inactivated plasma and a blank sample. So also you need, of course, a blank sample. This mixture is incubated for 20 minutes at 37 degrees, and then subsampling happens, and 1 to 40 diluted with imidazole buffer of pH 7.4. This sample is mixed with purified factor IX-A and factor X and incubated for 5 minutes at 37 degrees. And after this incubation time, factor X sensitive chromogenic substrate is added and the measuring is started. And it is measured the extinction, change in extinction of the sample. And after this step, you can read the inhibitor activity from a curve like Gary showed you, or you can calculate the inhibitor activity by using the equation inhibitor activity is 2 minus log residual activity divided by logarithm of 2. So we did a preliminary validation of the results, and we used this algorithm for for the samples. So we started with an undiluted sample. When the undiluted sample, when the inhibitor activity is less than 0.6 Bethesda units, you can say there's no inhibitor detectable. But with inhibitor activities between 0.6 and 1 Bethesda unit, you can easily report the result. Inhibitor activities between 1 and 2, you have to repeat the analysis in 1 to 2 and 1 to 4 diluted samples, because sometimes it happens that samples with a very high inhibitor activity still have still show in undiluted samples an inhibitor activity of 1.8 or 1.9. So to prevent that you give this erroneous results, you have to certify that your the inhibitor activity that you find between 1 and 2 is really between 1 and 2. If the diluted samples also give results of less than 2 Bethesda units, you can report the result of the undiluted sample. When the dilutions give results that are more than 2 Bethesda units, you have to repeat the analysis with more dilutions. And also when you find in your undiluted sample an inhibitor activity then of more than 2 Bethesda units, you have to, of course, you have to perform analysis in more dilutions, and at last you will get a result and use a dilution which has a residual activity closest as possible to 50%. At least it has to be between 35 and 70% for a reliable result. So with this algorithm, we did a preliminary validation of the method. First, we looked at the specificity. We analyzed 11 samples from normal individuals, and we found activities, factor VIII and inhibitor activities of 0.0 to 0.1 Bethesda units, suggesting a very high specificity. We looked at the reproducibility between run variation. And we used 3 samples, one with a high inhibitor activity, about 28, one with a median of about 4.5, and one with a low inhibitor activity, 1.6. The low inhibitor sample was tested undiluted, of course, and the medium and high inhibitor samples were tested in different dilutions. And we found coefficient of variation between run variation varying from 3.8% to about 8.9%. We looked at the linearity, and we started with the dilution of a sample with 2.6 Bethesda units inhibitor activity, and we diluted it to less than 10% of this inhibitor activity. And I think this is a quite linear relation between the inhibitor activity and the dilution. And when we look at the lower end of the curve, and we at the greater dilution of this sample, then it's also it shows also a very good relation between the activity that we measure and the percentage of the dilution. Of course, important is the correlation with the Nijmegen assay. And we analyzed 6 samples with this rapid inhibitor assay, and we correlated it with the Nijmegen assay, and these are the results. On the x-axis is the rapid assay, on the y-axis is the Nijmegen assay, and the conclusion is that there is a very good linearity between those two methods. Also, we looked at the accuracy with samples from the proficiency testing of the ECAT. So we analyzed 4 samples of ECAT proficiency testing, and we compared the results, our results of the rapid assay on the y-axis with the results of the other chromogenic assays that were tested in the ECAT survey. And the rapid assay is a little bit lower than the other chromogenic assay, but when we look at the reference chromogenic assay, so that means our data compared with the chromogenic assay of the same kit of, in this case, Technoclone, then there's a very good correlation, except for one sample. So, I come to my summary and conclusion. We have developed a fully automated, on the FVIII, a fully automated rapid factor VIII inhibitor assay using full-length recombinant factor VIII, COVAL3 as substrate, and a chromogenic factor VIII assay for analysis of residual activity. Primary validation of the assay shows a high specificity, a good reproducibility and linearity, an adequate accuracy in samples of external proficiency testing programs, and a high correlation with the Nijmegen assay in clinical samples. But I need that, of course, we only analyzed a limited number of samples. That extended validation needs to be performed in order to explore the clinical relevance of this method. And finally, I want to thank Nicolaus Binder for supporting me with the FVIII and different chemicals that we needed, Gary Moore for his scientific advice, Petra van Velp for her almost lifetime help, and Robert Pollineman for helping me with the experiments. Thank you very much.
Thank you very much, Bert. As we are already almost 10 minutes over time, I think I would like to ask if you have questions, just come to the presenters after the talk and we conclude the session. Thank you very much for spending your lunch with us, and have a nice end of the conference.